The broadcast is now starting. All attendees are in listen-only mode.
In my life, searching for the right, but it keeps avoiding me. Sorrow in my soul, cause it seems that wrong really loves my company. He's more than a man, and this is more than love. The reason that the sky is blue. The clouds are rolling in, because I'm gone again. And to him I just can't be true. And I know that he knows I'm unfaithful, and it kills him inside to know that I am happy with some other guy. I can see him dying. I don't wanna do this anymore. I don't wanna be the reason why. Every time I walk out the door, I see him die a little more inside. I don't wanna hurt him anymore. I don't wanna take away his life. I don't wanna be a murderer. I feel it in the air as I'm doing my hair, preparing for another day. A kiss upon my cheek as he reluctantly, as if I'm gonna be out late. I say I won't be long, just hanging with the girls, a lie I didn't have to tell. Because we both know where I'm about to go, and we know it very well. Cause I know that he knows I'm unfaithful, and it kills him inside to know that I am happy with some other guy. I can see him dying. I don't wanna do this anymore. I don't wanna be the reason why. Every time I walk out the door, I see him die a little more inside. I don't wanna hurt him anymore. I don't wanna take away his life. I don't wanna be a murderer. His trust. I might as well take a gun and put it to his head. Get it over with. I don't wanna do this anymore. Anymore. I don't wanna do this anymore. I don't wanna be the reason why. And every time I walk out the door, I see him die a little more inside. And I don't wanna hurt him anymore. I don't wanna take away his life. I don't wanna be a murderer. A murderer. No, no, no.
Good morning, everybody. That was Rihanna, and I think most of you know her. And I think several other songs today will also be by Rihanna. And I'm Dr. Minarsik. And today is December 28th. It's a few days after Christmas. It's Tuesday. It's 9 o'clock in the morning here in the Central Time Zone, Standard Time in Chicago area. And I'm happy to be here, and I hope you're happy to be here too. This is going to be a little bit of a different sort of webinar. That usually we either have, PowerPoint presentations and discussions, or we have labs. Today we're going to have both, okay? We have slated 4 webinars for the respiratory tract. The first one we did upper, or what we called ENT, which included part of upper GI as well. And then we talked into the about the non-pneumonia, non-cancerous lungs diseases, And then the last webinar last week, 5 days ago, we talked about primarily the various kinds of pneumonias. Now today we have a little bit left. Today we're going to be talking about lung tumors, okay? And it's not going to be an extremely lengthy presentation, probably less than an hour. I don't know. If it goes the entire first hour, I'm going to be kind of disappointed because we have a lot more to talk about after that. We'll be going into the laboratory again, okay? We have been terribly neglecting the lab. So after we talk just a few words about lung cancer, we're going to go into a lab and make up for lost time because we haven't had a lab in a while. And we'll be showing primarily lung diseases in virtual microscopy with our glass slides. So how about if we close off this guy over here and we pop open the PowerPoint and we talk about lung tumors, okay? Well, I think we already know that for both males and females, lung cancer is the #1 killer. It's not the #1 incidence of cancer, but it's the #1 killer because the #1 incidence for men is prostate and the #1 incidence for women is breast, but they do not have the high mortality that lung tumors or lung cancers specifically do. And well, I don't know if I could say this easily, but I just had a very close family member that passed away of a lung tumor. And the sad news is only 15% of the people with lung cancers of various types overall have a 5-year survival. Okay? Lung tumors can be benign. We've always divided our discussions of neoplasms into benign and malignant. They could be epithelial origin, or they could be connective tissue or mesenchymal origin. Or in the case of lung, there's a sort of a common lung cancer that's called neuroendocrine. It's also called small cell carcinoma. In the past, it was also called oat cell because they looked like little tiny oats. So small cell, oat cell, neuroendocrine, those are pretty much all the same term. Most of the primary lung tumors are carcinomas, and like you said, it's the biggest killer. Now, we spent a whole lot of time talking about pathogenesis and causes at the genetic level even. So probably the big cause worldwide, tobacco, and specifically the tires in tobacco. And the family of polycyclic aromatic hydrocarbons. Okay, benzpyrene is one of them. The benzanthracenes, as well as a role with the radioactive isotopes also, you know, like radon, as contributing to the causes of lung cancers. And when I say tobacco is the #1 cause, and the compounds in tobacco as being promoters and initiators, but primarily promoters or carcinogens, even though some of them have to be metabolized to be carcinogenic. That's probably true with both types of the common lung cancers, the small cell as well as the non-small cell. Radiation has an effect. Asbestos, as we know, has a very, very strong causative effect with the mesotheliomas, but also adds to the primary pulmonary carcinomas as well. Radon present a radioactive gas present often in basements because it's so heavy, okay, it basically tends to go to the lower parts of the house. And we also mentioned various genes and their mutations, which are indicted or causative factors or cause, or being mutated cause the changes in loss of growth regulation, such as c-MYC, the KRAS mutation, EGFR, the HER2/neu. Okay, these are all genes and their mutations, which we're not going into again because we spent a lot of time about when we talked about neoplasms in pulmonary carcinoma. Okay, this is a very interesting slide, and it's one of my favorite slides, because when you talk about the pathogenesis of lung cancer, now we're going to use the model as one of the most common types of lung cancer, the squamous cell carcinoma, okay? The normal bronchial mucosa, if you remember from histology, is pseudostratified, ciliated, columnar epithelium, okay? It's basically one cell. It has some cilia, may have some mucus cells as well as submucosal mucus glands. This is a normal histology in the bronchi, okay, which is where the majority, if not virtually all, of the squamous cell carcinomas arise. With chronic irritation, you can get now a metaplasia, okay, from the single columnar epithelium into sort of a stratified situation here, or squamous metaplasia. Here's some mucus glands. Here are some columnar glands still, perhaps ciliated, but you can see they're starting to be a stratifying effect as well. How about if we go to the next step and see that this is definitely metaplastic now. Okay, this is no longer columnar, it's no longer mucinous, it's no longer a single layer, but it is stratified. And you can see it's even starting to flatten out, perhaps even what you might call keratinize, okay? But of course, it doesn't have a stratum corneum, or does it? So this is the end result of chronic bronchial irritation. Let's say whatever irritates the mucosa, and let's get primary thing being cigarette smoke. How do you like that? Perhaps after many years. Well, perhaps even after many more years, you now have still a squamous metaplasia where the squamous cells have replaced the columnar cells. But take a look. Here, I'm going to make this bigger. Can you see that some of these cells are atypical? Okay, well, this is worrisome. This is dysplasia. This is precancer. And also, the most important thing to study in this particular field is that there is still a very sharp delineation between the epithelial cells and the basement membrane, okay? I don't think anybody would call this carcinoma in situ, but they would say it could probably go into it with further time. Okay, and here we are, perhaps something you might call severe squamous dysplasia, because now the atypia, the disorganization, the lack of maturation from tall cells to flat cells is severely disrupted. You see some abnormal mitoses. Now, if half of you want to call this carcinoma in situ, if half of you want to call it severe dysplasia, I don't care, because it's basically the same classification, something we would call CIS, or specifically CIN. But once again, now the single most important realization is that still the delineation between the epithelial squamous cells and the deeper connective tissue is very, very sharp, okay? And of course, if you would examine all of the bronchi in this area and see these types of changes, the most important thing is to see if any of these cells have infiltrated or invaded, perhaps even entered some of these lymphatic or blood vessels, because once it does, it is potentially metastasizable, okay? And here we have, finally, I think at the end here, something I'm going to show you. Looks pretty red. But now we can see connective tissue in these light areas here and here. And here's a stain that emphasizes the epithelial cells. And yes, they still have atypia, but look, they are no longer limited to one side of the basement membrane. This is an infiltrating squamous cell carcinoma, probably the most common type of lung cancer. You know, the adenocarcinomas are very, very common too, but classically, squamous cell carcinoma resulting from squamous metaplasia and progressive dysplasia to carcinoma in situ is what is always given as the model for lung cancer, even though it's one of the types of lung cancer technically. Let's make this very easy for you. Practically speaking, there's two kinds of lung carcinoma. There's non-small cell and there's small cell. Okay? Now, I don't know why they list the most common type as the non-small cell, but it is. The vast majority are small cell, are non-small cell. They're epithelial cells, ultimately cells which would have given rise to the bronchial mucosal epithelium. And then there's small cell, which is not technically an epithelial. It falls in the range of neuroendocrine carcinoma. But anyway, let's make it simple. There's small cell. You might think the cells are small because they are, and that's why it's called small cell. Previously oat cell, and now a lot of people want to classify these with the neuroendocrine carcinomas because they have a tendency to secrete a wide variety of ectopic hormones. And the non-small cell, and we said that the most common type of non-small cell is the squamous cell carcinoma, but perhaps not far behind are the adenocarcinomas, and then you have what we would call the large cell carcinoma, which are not the same derivation as the small cell, but they're just larger, and they're still in this family of squamous adeno. In fact, it's possible that some of the cells carcinomas that are called large cell carcinomas could possibly be perhaps very, very poorly differentiated squamous cell carcinomas or adenocarcinomas, okay, because they share the same markers very often. So there we go. Let's make your life easy. These types represent probably 99, maybe 95% of all primary lung malignancies. Now, if you wanted to be a real hot shot and realize there are other types of cancers of the lung besides the squamous cell, besides the small cell, besides the adenocarcinoma, which has a wide variety of adjectives as well. For example, there are acinar adenocarcinomas, papillary, bronchoalveolar, mucinous, solid, mixed, okay? But they're basically all a glandular appearance and probably the same origin of ultimate cells that give rise to these squamous cells and the adenos as well. Of course, these large cell carcinomas are probably also derived from the same group of cells, but the small cell carcinomas are not, okay? That's a special type of cancer. Unfortunately, it's classically the most aggressive. Perhaps some of the good news is perhaps they are probably historically the most potentially responsive to chemotherapy, okay? Of course, you could have neuroendocrine carcinomas, which could be called large cell as well, and that's still in the family of the small cell carcinomas. Could you have cancers that have both squamous or keratinization or pearl formation, as well as glandular features? Yes, you can. There are adenosquamous carcinomas. And remember, these are all epithelial malignancies. You can have carcinomas that also share sarcomatous type of malignant changes as well, having both carcinoma as well as sarcoma changes. You would imagine these would probably be more aggressive or worse in behavior than the pure carcinomas if they have a sarcomatous element, because everything else being equal, sarcomas are worse than carcinomas. You can have a carcinoid tumor that's also technically of neuroendocrine origin. It can also secrete a variety of ectopic hormones. We talked about the carcinoid tumor secreting serotonin earlier before. Okay, they could be typical carcinoids, or they could be sort of atypical, in which they may look or be feared to turn into small cell carcinomas. So could you say that a carcinoma tumor is also endocrine or perhaps neuroendocrine in origin? Yes, you can. Could you have cancers of the lung that look like the salivary gland cancers? Yes, you can. Pretty rarely. And of course, in all honesty, if you can't easily classify them into one of these categories, you could call it an unclassified carcinoma, which is very, very rarely done. Okay? However, rather than memorizing this big list, which you may have already, but rather than memorizing this big list, think of the normal histology of the lung. Okay? When you take a beautiful representative cross-section through the lung, you see probably at least half air spaces, all of these clear areas, most of which are tiny alveoli, and then the bigger air spaces, which are likely to be lined by a columnar or cuboidal epithelium, which are the bronchioles, and of course the ones which may have cartilage surrounding them. Maybe there's a little piece of cartilage there, I'm not sure, are the bronchi. Okay, and everything else, all the other spaces may be filled with blood, which are either arteries or veins. Perhaps that's oversimplifying the histology of the lung, but ask yourself, what kind of tissues are here? Well, could you have a tumor of blood vessels? Yes. Could you have a tumor of cartilage? Yes, benign or malignant. Could you have tumor of the bronchial epithelium? Yes, in fact, those are the non-small cell. In the lung, you may find little groups of neuroendocrine cells also. Classically, they have been called Kolchitsky cells. And those are neuroendocrine cells, and people believe that the small cell carcinomas are ultimately evolving or arising from these neuroendocrine cells, because those are the only parts of a normal lung in which you might see neuroendocrine cells. Here's another nice picture, something you would expect to see in the pathology lab. Here's a trachea. Here's a main stem bronchus. Here's a main stem bronchus. And you could see that this main stem bronchus very soon becomes obliterated, obstructed by a big tumor. And if you would think that the lung tissue peripheral to this would collapse or atelectasis because the bronchus is obstructed, then that's the general principle as well, okay? This is the classical squamous cell carcinoma, and that's why it's called also, generally synonymously, bronchogenic carcinoma, because it arises in the bronchus. And probably most, if not all, of this white, firm, non-spongy tissue here is cancer. If this patient had a sputum done before death, or even if you took some of these cells and smeared some of the tissue onto a slide, you might see epithelial-looking cells that are very, very big, very, very dark, very, very irregular. And of course, these would be an indication that indeed there is a cancer present. Now, could you tell just from the cytology whether this was a carcinoma in situ or a carcinoma that was infiltrating? And of course, the answer is no. So a person with a mass or infiltrate on a chest x-ray having sputum that looks like this might be concluded that this is an infiltrating carcinoma, because these are, by all cytologic definitions, malignant cells. Big, dark, high nuclear cytoplasm ratio, clumped chromatin. These are all instantly, without going into all the details, instantly reflex as a malignant group of cells. Now, I told you there's two kinds of cancers, right? I said that there's non-small cell and there's small cell. And I said that the non-small cell were squamous, adeno, and large undifferentiated cells. So can I ask you a question? You don't have to respond, but if you do, I'll be thrilled. If this was part of a lung cancer and there was a nice little cluster of cells which look like they sort of keratinize, sort of in the middle, and they don't have tubular or glandular features at all, you'd probably call this a squamous cell carcinoma. And you can see, obviously, it's surrounded entirely by fibrous tissue, so it's infiltrating, okay? anything that looks granular or circular or tubular and also has a wide variety of nuclear changes would fall into the category of one of the many different subtypes of adenocarcinoma. Okay, so this is another non-small cell carcinoma. These two cancers, the squamous cell carcinomas and the adenocarcinomas, comprise the vast majority of not only non-small cell cancers, but the vast majority of cancers of the lung in general. Now take a look down here. I think you'll agree that that's a big, dark, ugly, malignant cell. Probably is that. You could also see it's surrounded by a lot of inflammatory cells and perhaps connective tissue. You would say, well, you know, they're big cells. They look like they might be perhaps epithelial, but they don't clearly form glands and they don't clearly keratinize or form these pearls. So I would call this a large cell carcinoma. And often the term large cell undifferentiated carcinoma is applied to these as well, because they don't differentiate into glands or squam. And if you were to do markers, you know, with immunohistochemistry, you would find that these cells perhaps would be very similar in histochemical appearance. Now I know what you're thinking. We got one left. And in these cases, you have large cells with large nuclei and even a lot of cytoplasm. Same thing here. Large cells, big nuclei, a lot of cytoplasm. But take a look down here. These are small cells. Okay, this is small cell carcinoma. They're almost entirely nucleus. They don't have much cytoplasm, and that's why they're called small cells. Okay. And these are not derived from the same type of cells that the other three non-small cell are. Furthermore, I'm going to show you more pictures, and we're going to see have a lab showing all these after in the second hour. But these are the ones that are more likely to, well, I'll tell you three things about small cell carcinoma relative to these three non-small cell carcinoma. They're more aggressive. They tend to grow faster, obviously, and therefore they tend to become necrotic. They're likely or often endocrinologically active, secreting a whole host of ectopic endocrine hormones to cause a endocrine paraneoplastic syndrome. And also very often, even though the nuclei should be generally round, they generally like to crush each other. The term that's used in the pathology reports when they describe small cell, formerly called oat cell or neuroendocrine cell, we'll say, is that the nuclei are molded. In other words, they tend to squish when they're next door to another cell. Let's see if we could, oh no, I don't think we could blow it up, but we're going to see more pictures of this. So here we go. Small cell in the southwest and non-small cell in the other three quadrants. The staging for lung cancer is crucial because it determines the type of therapy and the overall prognosis, okay? It's much more important to stage a lung cancer than to grade it, saying, well, is this squamous, adeno, large cell? You know, the pathologists love to do that. And there are differences overall in prognosis, but they aren't nearly as prognostically important for survival and for therapy and types of therapy as the staging. And the classic lung staging method for lung, as well as many other systems, is TNM, tumor, node for lymph node, and metastasis. So if a tumor is small or less than 3 centimeters, they might call it 3-1. That could be measured by the surgeon, by the radiologist, or by the pathologist, okay? If the tumor is more than 3 centimeters, they might call it 3-2. Or the main stem bronchus from the carina with pleural involvement, or atelectasis, these are T2s. If it goes beyond the lung into the chest wall or diaphragm or anything surrounding the lung, that would be T3, no matter how big it is. If it actually invades the mediastinum, heart, the great vessels, trachea, esophagus, vertebral body. We're going now more invasion, and that's the highest stage of T, which is T4. The N is real easy. If there's no lymph nodes involved, it's N0. If there's lymph nodes involved, but it's only on one side or peribronchial, okay, then it's N1. If the lymph nodes are ipsilateral but extend to the mediastinum or subcarinal, which is much deeper, then that's N2. And if there's contralateral metastases, that's N3. The M's are real easy. M0 is no known metastases by all clinical, radiologic, surgical, pathologic inquiries. If there's no known metastases outside of the tumor itself, that's M0. That's pretty logical, isn't it? And of course, any distant metastases would put it into M1. Okay. I think these should all be very logical because we're talking about the clinical feature versus the pathologic tumor extent, okay, or involvement. Well, could a cancer block a bronchus? Could it interfere with blood supply and therefore cause an abscess or a pneumonia or atelectasis if it was obstructed of bronchi? Of course. So atelectasis would be due to tumor obstruction of the airway. There's a certain type of pneumonia that's called lipid pneumonia, and it's not specific for cancer, but very often when you have tumor obstruction and necrosis, the accumulation of macrophages chews up a lot of the necrotic fat, and it causes a type of appearance, foamy histiocytes. Of course, lipid is the foam of the foamy histiocytes, so it causes a lipid pneumonia. I think I've heard the term lipoid pneumonia too. So lipid pneumonia due to tumor obstruction and foamy macrophages. Could it extend to the pleura and cause an effusion? Of course. Okay. Could it cause hoarseness? Of course. Because if the tumor is involving the laryngeal nerve, then you're going to have some problem with hoarseness or, let's say, speech. The tumor invades the esophagus. You could have dysphagia, difficulty swallowing. Could the tumor paralyze the diaphragm? Well, if it affects the nerve that controls the diaphragm, the phrenic nerve, of course it can. Could it cause rib destruction? Of course, because that would be due to chest wall evasion. Could it compress the superior vena cava and cause the SVC syndrome with dusky cyanosis of the upper extremities and neck? Yes, of course. These are all, I hope, very logical to you. There's another syndrome that's called Horner syndrome. And basically, Horner syndrome is due to sympathetic innervation ultimately between the brain and the eye. And Horner syndrome classically is somebody with constricted pupil on one side, okay, no sweating on that half of the face where the pupil is involved, called anhidrosis. And of course, we talked about exophthalmos meaning bulging of the eyeball, anterior to the orbit, but in enophthalmos, it actually causes a sunken in type of appearance. So those are the three features of Horner syndrome. And I guarantee you, for some crazy reason, these items you should probably know because they're almost on every step one exam I've ever heard of, okay, in one way or another. We talked about the lung cancers, and particularly the small cell cancers, even though some of the non-small cell cancers can excrete ectopic hormones and cause a hyper expression of the hormone or a paraneoplastic syndrome. It's much, much more likely that a small cell will cause a paraneoplastic syndrome than non-small cell, but both are possible. So, what if there's an overexpression, or what if the tumor produces ADH? Well, doesn't ADH save sodium, so you'd have hyponatremia, okay? What about ACTH, Cushing syndrome, and overproduction ultimately of corticosteroids? Yes. Parathyroid hormone can be expressed. In that case, you're going to have a hypercalcemia. Some of the lung cancers can express calcitonin, so that would be a hypocalcemia, just from the normal action of these hormones. And the thing I want to bring up is that the actual ectopic hormone may not be exactly the same amino acid sequence as the normal intrinsic hormones. They may be off by a couple of amino acids, but they still would have the endocrine effect. Could you have gonadotropins or hyperexpression of male or female characteristics? And finally, we saw that the carcinoids of the GI tract can secrete serotonin, causing flushing and diarrhea. Well, guess what? Technically, you can have carcinoids of the lung as well as an expression of another hormone involved in pain, bradykinin, which we said was also one of the common mediators of acute inflammation. So here we go. Once again, I don't want you to remember every single cell here. I can barely do it myself. But I want you to remember that the majority of this cross-section are air spaces, and the majority of air spaces are small alveoli. The larger ones, air spaces, may be lined by actual columnar or cuboidal epithelium, and anything that's red in the middle is blood. And you may even see some cartilage. You know, if you're really, really lucky, you may see a group of Kolchitsky cells every now and then. But just remember, anything here that's a cell can have a benign or a malignant tumor. You know, even including things like, macrophages in the alveolar wall, for example. Okay, so anything is possible. And that's what caused the big list of lung tumors. We already know the little list because there's only 2 of them. Okay. A malignancy occurring anywhere in the body is most likely to metastasize to the lung, or maybe even the lung first, okay? So in other words, the lung is the most common site for all metastatic malignant tumors, regardless of wherever the tumor originated. Now, the thing that you should also know, if we have divided malignant tumors or cancers into carcinomas and sarcomas, the malignant sarcomas, the connective tissue tumors, have a preference, okay, much more than a carcinoma, for invading blood vessels rather than lymphatics. So it's very, very often, and I have another close family member, as well as many other people that I've known in my long life, where they've had a sarcoma and the presenting symptom was a pulmonary problem, even though the sarcoma may have been, 1,000 miles away in the toe, for example. So keep that in mind. The presenting system of sarcomas may be a metastasis to the lung. Okay, we're doing pretty well. We're probably ahead of schedule in terms of the hour because we have only one more thing to talk about. But then we're going to close off the entire chapter and do a lab in the rest of the hour and the second hour, because now we're going to talk about pleura. Okay, the pleural cavity. Pleural cavity is lined by mesothelial cells, both along the lung itself, the lung surface, the visceral pleura, as well as along the chest wall and diaphragm, the so-called parietal pleura. Okay, that's also true with the pericardium and the abdominal cavity. It's a space in which both the inner as well as the outer lining of that space is lined by mesothelial cells. So pleural cells are primarily mesothelial cells with connective tissue underneath them. The inflammation of that due to any cause would be called pleuritis. Clinically and even pathologically, sometimes you'll hear the word pleurisy, but for all practical purposes, pleurisy as a painful clinical syndrome and pleuritis as a pathologic entity are pretty much synonymous. What would you call air in the pleural space? You call it pneumothorax. That's pretty logical. What would you call excessive fluid in the pericardial space? Well, you'd call it an effusion, okay? Or you might call it a hydrothorax if the primarily fluid was watery, for example, just like you might call it a hydropericardium if the fluid in the pericardial pleural mesothelial line space was it, or peritoneum, okay, also called ascites. Hemothorax if it's blood in the pleural space. Chylothorax if it's primarily a chyle fluid, okay, fluid from lymph drainage can accumulate in the pleural space, as well as in the pericardial space or the peritoneum. Are you starting to see a pattern here? Okay, they all parallel each other. You know, hydro, hemo, chylo, okay? Just like not only in the thorax, but in the pericardial space or the peritoneal space, even though they have other synonyms. And then we'll talk about mesotheliomas, okay, which are the primary tumors of pleural lining cells or pericardial lining cells or peritoneal lining cells, which are the mesothelial cells. So what causes pleuritis? Well, overall, the same bacteria and viruses in this whole big list that we went through with lung can also involve the pleura, either directly. Now, it's very common and even usual for a pneumonia to involve the pleural space, okay? It's not very common for a primary pleuritis to cause a pneumonia, but it's very, very common for a pneumonia to cause a pleuritis. Now, if you remember when we talked about lung infarcts, we said that they are usually very, very peripheral. So you may have their primary gross appearance in the peripheral portions of the lung, which of course is the visceral pleura, okay? Could you have abscess material within the pleural space? Yes. In fact, it has a special name. It's called empyema. We said that that can happen with the infectious pneumonias as well. Tuberculosis is a type of pneumonia, and worldwide it's a common cause of a pleuritis, which of course is going to express itself as painful. Why? Because the lung itself does not have pain endings, does it? But the pleura does. Okay, both the visceral and parietal pleura. Now, another common cause of a pleuritis would be the systemic autoimmune diseases, of which rheumatoid arthritis and lupus and even progressive systemic sclerosis or scleroderma is also a common cause to inflame, cause a painful pleuritis as well. I think probably one of the most common causes of a pleuritis is uremia. Because patients that die with renal failure, long-standing renal failure, very, very often have a very significant inflammation of the pleura, especially the visceral pleura, or especially the space between the visceral and parietal pleura. It may even be very, very, very fibrinous and hemorrhagic. So a fibrinous pericarditis or a fibrinous pleuritis, the first thing that you'd probably think of in most patients would be renal failure with long-standing uremia. And of course, metastatic disease that also involves the lung would also or could also involve the pleura. So basically that's your differential diagnosis of pleuritis. Now let's say you didn't have inflammation in the pleura, but you had air. Okay, well, why would somebody have air in their thorax? You know that the pressure of inside of the pleural space is less than atmospheric pressure, okay? So it should not accumulate air, correct? In some people, even younger people, there could be a spontaneous pneumothorax, okay? Sometimes it's idiopathic, sometimes it's not known, but technically any breach of that space, you know, from either the chest wall side or the bronchial side could introduce air into the pleural space. How about a gunshot wound? How about a stab wound, okay? In some cases, not really too much done anymore. There have been what they call therapeutic pneumothoraces, particularly in tuberculosis, done many years ago, but not too much now, in which you would introduce air into it for a therapeutic relief, okay? If the air enters from the chest wall side, then that's called an open pneumothorax. If the air enters from the air in the tracheobronchial tree, then that would be called a closed pneumothorax. If the air inside of the pleural space becomes trapped and has a pressure effect, not only of the underlying lung, perhaps even mediastinal structures, then that's called a tension pneumothorax. Now, if you have a air in the pleural space, okay, but it's more likely to come in rather than go out, that's what they might call a valvular effect, in which perhaps, you know, the pneumothorax gets progressively worse because the air can come in, but it can't come out, you know. That's a phenomenon that's often described as well. But probably one of the most common causes of a pneumothorax would be an emphysema bleb, okay? We also call those things emphysema sacs, okay? Think about it. Let's say that you have a peripheral overextended air sac peripherally, and that pleura ruptures, okay, then that would cause a pneumothorax due to rupture of an emphysematous bleb, okay? Of course, perforating injuries, nice injuries, stab wounds, gunshot wounds. And I'll tell you, the radiologist will also tell you, even when they do needle biopsies of the lung, which has miraculously saved morbidity and mortality over the diagnostic surgical biopsies, it's very, very often that you will have a pneumothorax simply because of the needle that's been stuck into past the pleural space and into the lung. And they're usually very small. Sometimes they grade these as percentages. You know, perhaps a small pneumothorax would be a 5-10%. Some of the large, perhaps tension pneumothoraces, you know, might be much higher, 30, 40, 50%, okay? But in most cases, in fact, almost all cases, the radiologist, when he does a chest x-ray after he does his needle biopsy and there's air introduced there, it's usually a small amount, and they usually, most pneumothoraces like this, spontaneously resolve. Could you have fluid in the pleural space? Of course you can, okay? If the fluid was primarily water, in other words, low in cells, low in protein, low in specific gravity, that would be called a transudate hydrothorax. If the fluid had a significant a certain amount of protein or a higher specific gravity or a lot of cells, perhaps even malignant cells, that would be called a hydrothorax. That's an exudate. And of course, blood has the name hemothorax, just like blood in the pericardium would be hemopericardium, and blood in the abdomen would be a bloody ascites, okay? Could you have lymph as a fluid in the pleural space? Yes, that's called chylothorax. And I got news for you. I've seen a few of these myself, and if you do a pleural tap, in other words, you aspirate the fluid from the pleural area, and it looks like milk, I can't think of anything else it could be except chylothorax, which usually means obstruction of the thoracic duct. And what can obstruct the thoracic duct? How about the number one thing would be a lung cancer, okay? And finally, we'll talk about tumors of the mesothelial-lined pleural space, which are known as mesotheliomas. And like all tumors, we can call them benign or we could call them malignant, okay? They don't have all the classical features of the usual benign versus malignant, and you will very, very rarely hear the word malignant mesothelioma on the pathology report. You'll hear mesothelioma, which means there's been a unregulated growth of mesothelial cells. Could this unregulated growth cause compression of the lung? Yes. It doesn't usually cause infiltration directly. It usually has what they call a pushing margin. Now, where do you get mesotheliomas? Well, anywhere where there's mesothelial cells. The visceral pleura, perhaps growing inward with a pushing margin, but not a directly infiltrating margin. Could it be in the chest wall, appearing as a nodule, and perhaps even compressing the lung from the parietal pleura? Could you get them in the pericardium mesothelium? Yes, either visceral or parietal. Could you get them in the peritoneal mesothelium? Yes, either visceral or parietal. They're very, very common, and the number one cause or the number one risk factor is asbestos exposure. There are probably other things, but the term mesothelioma is usually implied that there's been some exposure to asbestos. That's why this compound not only is indicted with the majority, if not all of them, of mesotheliomas, but also has a risk factor role with pulmonary cancers as well. Now, remember I told you that the mesotheliomas have a pushing margin? Now take a look at this lung. All of this white tissue is the mesothelioma, which has encircled the lung. This is an entire lobe, okay? It might even be an entire lung, but I think it's an entire lobe. And it pushes. Now, if you were to look at the margins of this between the mesothelioma and the lung, it would not be a directly infiltrating cellular type of picture. It would be just like putting a golf ball inside the lung and pushing the lung. So yeah, this is malignant. Why? It killed a patient. But the appearance may not have, and usually does not have, the usual cytologic or cellular features of malignant cells. Okay? And that's why you'll never hear the word malignant on the pathology report preceding the word mesothelioma, even though they behave malignantly like you see here. Now, when you do a pleural tap or a thoracentesis, you may see clusters of cells like this or like this, and you say, oh my God, are these mesothelial cells? Or is this adenocarcinoma? That is the number one problem that pathologists might have. And there is a variety of cellular markers that you could use. The oldest and probably most reliable one is a protein called calretinin. So if these cells here stain positive, with this chromogen, even though it looks like an adenocarcinoma, you can say this is a mesothelioma, because sometimes mesotheliomas can have a glandular looking appearance. And they can very, very easily be confused, and often are, with adenocarcinomas, unless you do a calretinin immunochemistry stain. Another feature of mesotheliomas, and I think this is logical too, here's a transmission electron microscopy, okay? Now even some of the glandular cells can have these little microvilli, but mesothelial cells, even if they are, aggressively growing, they have a very, very, very rich network of these microvilli at the apical surface. And why is that? Well, shouldn't it be logical that if you had only one layer of cells lining the entire surface of a lung, or a liver, or a spleen, or a pericardium, that they would have to maximize their surface area in order to function, even as a lining cell? So, mesothelial cells have a very, very generally rich network of microvilli compared to adenocarcinomas, which usually don't, okay? Now, are we done? Yeah, we're done. Well, let's see. I didn't want to go the whole hour, and I did, but we still have 10 minutes. So how about if we take our 10-minute music break? We are now completely finished with the chapter or the discussion of the respiratory tract. We'll probably start with the genitourinary tract in the next webinar, but we still have an hour left. So this gives us time to catch up with pathology lab and go to our virtual microscope after the music break. So I guess we could close this down completely, and we could say, don't save any changes. And now you see my granddaughter. And how about if I put up our little clock again by turning it that way? And we will see you in about 10 minutes after 3 more songs. And I know the next one is by Rihanna. Maybe they all are. So, buzzards, see you after the break.
Cheer. Rihanna. Good girl going back. Take 3. Action. No clouds in my stones. Let it rain. I hydroplane in the bank. Coming down like a Dow Jones. When the clouds come, we gone. We Rockefellers. We fly higher than weather. And G5s are better. You know me. In anticipation for precipitation. Stack chips with a rainy day. Jay. The Rain Man is back. With Little Miss Sunshine. Rihanna, where you at?
You have my heart, and we'll never be worlds apart. Maybe in magazines, but you still be my star. Baby, 'cause in the dark, you can't see shiny cars, and that's when you need me there. With you, I'll always share. Because when the sunshine will shine together, told you I'll be here forever. Said I'll always be your friend. Took an oath, I'ma stick it out to the end. Now that it's raining more than ever, know that we'll still have each other. You can stand under my umbrella. You can stand under my umbrella. Ella, Ella, 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 fancy things will never come in between. You're part of my entity, here for infinity. When the world has took its part, when the world has dealt its cards, if the hand is hard,
I heard you good with them soft lips. Yeah, you know word of mouth. The square root of 69 is 8 something, right? Cause I've been trying to work it out. Good weed, white wine. I come alive in the nighttime. Yeah, okay, away we go. Only thing we have on is the radio. Oh, let it play. Say you gotta leave, but I know you wanna stay. You just waiting on the traffic jam to finish, girl. The things that we can do in 20 minutes, girl. Say my name, wear it out. It's getting hot, crack a window, air it out. I can get you through a mighty long day. Soon as you go, the text that I write is gonna say,
Oh, na, na, what's my name? Oh, na, na, what's my name? Oh, na, na, what's my name? What's my name? What's my name? Everybody knows how to work my body, knows how to make me want it. Boy, you stay up on it. You got this something that keeps me so off balance. Baby, you're a challenge. Let's explore your talent. Hey boy, I really wanna see if you can go downtown with a girl like me. Hey boy, I really wanna be with you, 'cause you're just my type. Oh na 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 na, I need a boy to take it over. Looking for a guy to put in work. Oh, 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 oh. Hey boy, I really wanna see if you can go downtown with a girl like me. Hey boy, I really wanna be with you, 'cause you're just my type. Oh na 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 na, I need a boy to take it over. Looking for a guy to put in work. Oh, 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 oh na na, what's my name? Oh na na, what's my name? Oh na na, what's my name? What's my name? What's my name? You got me, and ain't nowhere that I'd be than with your arms around me. Back and forth, you rock me, yeah. So I surrender to every word you whisper, every door you enter. I believe. Hey boy, I really wanna see if you can go downtown with a girl like me. Hey boy, I really wanna be with you, 'cause you're just my type. Oh na 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 na, I need a boy to take it over. Looking for a guy to put in work. Oh, 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 oh. You're so amazing. You took the time to figure me out. That's why you take me way past the point of turning me on. You about to break me. I swear you got me losing my mind. Oh na na, what's my name? 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 What's my name? What's my name? Hey boy, I really wanna see if you can go downtown with a girl like me. Hey boy, I really wanna be with you, 'cause you're just my type. Oh na 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 na, I need a boy to take it over. Looking for a guy to put in work. Oh, 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 oh. Hey boy, I really wanna see if you can go downtown with a girl like me. Hey boy, I really wanna be with you, 'cause you're just my type. Oh na 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 na, I need a boy to take it over. Looking for a guy to put in work. Oh, 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 oh.
If I may, I would love to ask Josh Groban to come on stage with me tonight and sing the prayer with me.
I pray you'll be alright and watch us where we go and help us to be wise in times when we don't know. us to a place, guide us with your grace, to a place where we'll be safe.
La luce che tu dai
I pray we'll find your light
nel cuore resterà
and hold it in our heart.
a ricordarci che
When stars go out each night,
l'eterna stella sei nella mia preghiera.
let this be our prayer.
Quanta fede c'è
When shadows fill our days,
lead us to a place,
guide us with your grace, give us faith so we'll be
safe. Sogniamo un mondo senza più violenza, un mondo di giustizia e di speranza. Voglio simbolo di pace, di fraternità. La forza che ci dai, desiderio che ognuno trovi amore per noi dentro sé. Let this be our prayer, just like every child. Needs to find a place, guide us with your grace, give us faith so we'll be safe. La fede che hai acceso in noi. Sento che ci salve.
Yes, we had more of Rihanna during the break, but we also had Celine Dion, one of the most perfect female voices ever, okay? You know, during the break, I often realize some of the goofy things I said, some of the wrong things I said, and some of the lapses that I had in my brain. When we were talking about pneumothorax, we said that the blebs can rupture from emphysema and cause a pneumothorax. Of course, that would be a closed pneumothorax because the air is coming from the inside rather than the outside. And I couldn't think of the word bulla, okay? And sometimes this happens to us. I'm not exactly at the Alzheimer's stage yet, but a bulla is the same as a bleb, okay? I should have said bulla because that's the preferred medical term. Some people call them blebs. I call them blebs, but maybe some of the radiologists will, but they're really bulla. So that's the thing that kind of embarrassed me during the break, and I just had the strong feeling to apologize to you for it. So now we're actually done with the entire chapter on respiratory tract diseases, but we have a little time left. And I love to do labs. Why do I love to do labs? Because it's fun. And I really don't have to prepare much for them because it's the same slides that I've seen perhaps dozens of times during this course, and perhaps hundreds or thousands of times during my life. So yeah, we're going to have a lab right now, and we're going to show you some cases that we've been talking about, and we're going to catch up before we go into our next system of genitourinary, which, by the way, is a massive system. If there were 4 webinars for respiratory, there's going to be about 10 webinars for genitourinary, because you have upper, lower, you have male, you have female, you have breast. So there's a lot of stuff. But we're still on lung, so let's catch up with the lab and close down this guy with the big mouth and show you what we're going to be showing you. I don't know if I'll be able to show you all these cases. I guess if I showed them quickly, I could. I don't want to go another hour, over an hour. But these are the things we've been talking about. Now I want you to actually see them, because these are actually tissues taken from patients with these diseases. They're not pictures in textbooks where people are going to sue me for violating their intellectual property. Now we have the actual slides, which are public domain, and you could get these from the University of Iowa if they're still giving them out, and free, because they were supported by taxpayer funds. I guess the best slide to start out with is this one. It's called NORMAL. So I want you to keep this in mind when we look at all of our other slides. And I don't know if we'll get to see all of these, but we're going to see the main ones, that's for sure. Okay, here we go. I'm going to ask you a question now. Do you see the lung? One student said he had a hard time seeing the slides in the first hour, but I need to know. So yes, you can see the lung. This is the picture I also took when we were showing normal lung, but it's also the actual slide. So what are we going to do? We're going to go over the quick salient features again. Well, you know that these probably slightly thicker walled structures with blood are pulmonary arteries. Some of them with thin walls might be veins. Okay, you know the majority of this section of the sponge are the small tiny holes, the alveoli, and these bigger spaces lined by perhaps epithelium that's either columnar or low columnar or cuboidal are going to be bronchi. If the holes have cartilage next to them, you could call them bronchi. If they lost their cartilage, you could probably call them bronchioles. So here we go. Let's take a closer view and maybe get a little section through everything. All of these tiny holes are alveoli. Here's a bronchiole. If I saw a piece of cartilage here, I might call it a bronchus. Here's part of a pulmonary artery. You can see it's filled with blood. And I just want you to keep this picture in mind, is that really, think about it. Almost all of the cross-sectional area that you see here is white. Okay? What does that mean? It means it's mostly air. Okay? And this is what causes the lucency. Anything that interferes with this, 80, 70, 80% white might show up as an infiltrate on a chest x-ray. You know what? I think I'm going to see if I can make this fit the field of view of the camera a little bit better. Here we go. So we don't go over when we look at the movies. Yeah, that looks pretty good. And I could pull this guy down over here. So folks, blink your eyes like it was the shutter of a camera. And now we're going to look at the abnormal lungs, knowing this is probably the most normal lung that you'll ever see. Okay, what do you want to do next? Well, we talked about pneumonias for a whole day, so let's look at this thing here called bronchopneumonia. And remember, we said there's 2 kinds of pneumonias, bronchopneumonias and lobar pneumonias, and classically the bronchopneumonias originate from bronchitis. So that means that even though there's still a good amount of airspace here, in this area here towards the top, there seemed to be some loss of airspace or perhaps infiltration of cells. And we're going to zoom in on one. That's why we have the high power lens. And look, see this? This is a bronchial epithelial lining, probably columnar cells. These are all inflammatory cells, primarily neutrophils. And basically the pathogenesis of a bronchial pneumonia is for the inflammation to start in the bronchus and then spread here into the lungs. And these are primarily most of the common pneumonias that you will be treating, okay? This is a classical bronchopneumonia. I'm going to exit it, and I'm going to go to something here called lobar, because we said, remember, there's two kinds of pneumonias, bronchopneumonias and lobar pneumonias, of which pneumococcus or streptococcus pneumoniae is the most common type. So look, in here, looks like we have some type of pleural surface here, or maybe a fissure, and then we have a piece of lung in which there's no inflammation. There's a lot of air spaces, but in here most of the air spaces are filled with some kind of junk, which would cause a loss of lucency or an increase in density. So let's see what that junk is. Well, look, in here we could still see the outlines of alveoli, but inside of them are inflammatory cells, primarily neutrophils, fluid, and this is a classic, absolute, beautiful picture of the most common type of bacterial pneumonia, the kind of stuff you'll be treating. Also notice here that this is a pneumonia in which the primary inflammatory debris and action is inside the alveolus. Notice that the alveolar walls are still pretty thin. If the primary area of inflammation was in these walls, you might call it an interstitial pneumonia, okay? But this is an alveolar or bacterial pneumonia. Now, as a general rule, we've said this before, most bacterial pneumonias look like this in the acute phase, okay? But most viral pneumonias and many of the non-infectious pneumonias, the interstitium, or this wall between the spaces, is inflamed, and that's what we call an interstitial pneumonia. It could even lead to fibrosis and has a wide variety of causes, but basically they're generally non-bacterial. Take a little quick picture of that in your mind as well for the classical lobar pneumonia, of which pneumococcal pneumonia is overwhelmingly the most common cause. Okay, what do you want to do now? I guess we could do anything. Well, we covered the two most common types of pneumonias. Hey, we talked about emphysema too. Let's talk about emphysema. Let's do more than talk about it. Let's actually show it to you. Okay? What would you say in general about most of this lung? Is it 50% air spaces or more than 50%? This would be palpated as hypercrepitant or decreased density or increased lucency on the chest x-ray, even though surrounding in the area there are patches of inflammatory cells. Look at, might you call this a bleb or a bulla? Yes, it could be. What would happen if this bulla actually ruptured through the pleural, visceral pleural surface here? Then you'd have air in the pleural cavity, right? It's okay, this is basically something that would, and wouldn't it be obvious that where there are the most alveoli, which is subpleural, because towards the center of the lung you have more bronchi and vessels and so forth, that the most likely place to get a bulla or a bleb would be subpleural. And that's why when they rupture, they can cause a pneumothorax. And didn't we also say that people with emphysema or chronic obstructive lung disease, didn't we also say that they are very, very likely to come up with bouts of recurrent pneumonias? You know, like Moraxella or Haemophilus are the two most common ones. And look, you see this bronchus here, lined by that? You're seeing a lot of inflammation around it, and maybe even an early bronchopneumonia. I would call this microscopic early bronchopneumonia, although most of the other parts of the lung show normal or perhaps even hyperexpanded alveoli. And why are they hyperexpanded? Because when the patient exhales, the air is blocked. Okay? So let's go on to the next one. Hey, let's do an infarct. Okay? We're making pretty good time here. So how about if we look at what we call an infarct? Do you remember when we talked about infarcts and hemodynamic disorders, we said that if a tissue has its blood supply blocked off, okay, the first question you ask, is there a secondary blood supply? If there is, it usually does not infarct. But if both blood supplies, like in the lung or in the liver, in the lung it would be the pulmonary circulation and the bronchial circulation. If this patient had a thromboembolism obstructing the bronchial circulation, and perhaps he also had congestive heart failure, impairing the bronchial circulation, he would have an infarct. And these infarcts are peripheral, and I've seen many good pathologists actually put on a blindfold or close their eyes and palpate the external surfaces of a lung to see if there's any densities along the side that are hemorrhagic. So an infarct of the lung is usually hemorrhagic because it has a dual blood supply, and it's usually subpleural as well. So this is all blood, no cells, no tissue. Looks like it's even dead tissue, whereas the part of the lung that is not infarcted still has a lot of residual air spaces. Let me ask a question. Okay, I see a lot of you are making comments. I wish I could answer all of them. But here's my question to you, and I hope some people answer. Am I going too fast or too slow or just right? Hello? Okay, I'm seeing just right, so thank you very much. Here is another very important pathologic condition of the lung. It's called acute pulmonary edema. If you had a left heart failure, the pressure of the left atrium would increase. That would back up into the pulmonary circulation, and you would then have a increase in hydrostatic pressure, or the tendency for fluid to leak out into the alveoli. Notice that except for the fluid in the alveoli, most of the lung is not inflamed. It just has fluid in the alveoli. So this fluid, perhaps a little bit proteinaceous, but this fluid basically appears white, okay? So if you think of a normal lung, but fluid in the alveoli, but no inflammation in the surrounding tissues, that's probably acute pulmonary edema. Okay, but what if that pulmonary edema or the congestive heart failure, which caused it, extended for hours, weeks, days, months? Then you'd have a tendency for not only fluid to leak out, but blood also. So we're going to show you chronic passive congestion of the lung, which I called CPC. And in chronic passive congestion, you're now going to have blood in the alveoli, not just watery fluid, but what else do we have besides blood? You're probably going to see some of the blood because it's been around for a long time, has taken up the blood pigment of hemosiderin. So the hemoglobin has now degraded or evolved or aged into the hemosiderin by a normal chemical process. And you can see that these cells here, and these here, and these here, and these here, these are all macrophages that have gobbled up the chronic blood. So hemosiderin macrophages is a sign of chronic hemorrhage, and in this case, chronic passive congestion of the lung. And why do we call it passive? Because it's passive, because it's actually the heart that has the primary problem and not the lung. Just like we saw with the acute pulmonary edema. Okay, we're doing good. I thought I was going to have to really rush, but let's get into some of the tumors. Didn't we say that the most common non-small cell tumor is squamous cell carcinoma? So, let's look at it. Of course, you know it's squamous cell carcinoma because it's labeled that way. So you know this has to be a big bronchus because it's just loaded with cartilage. This could even be a main stem bronchus. It's really big. And you could see cartilage here and here and here and here. And you could see some type of increased number of cells in the mucosa. And let's take a look at it. Well, they're arranged haphazardly. I'm going to blow it up even more. I'm going to convince you these are malignant cells. Look, they look like squamous cells. They're big, they're dark, they're ugly. They might even have little bridges between the cells proving it's squamous. They don't form glands. These are large cells that have bridges between them and they form glands, and by definition that's squamous cell. And I know what you're thinking. You're thinking, well, how do you know that this isn't just only in situ? Because it looks like the big wall of the bronchus itself doesn't look terribly invaded. Well, I'll answer that question. You see this piece of cartilage here? You notice the nice edges it has on it? And the piece of cartilage here, and the piece of cartilage here, and the piece of cartilage here. But look, let's take a look at this piece of cartilage right here. Okay? I'm going to zoom in on it. And I'm going to ask you, have these cells invaded the actual cartilage here and here and especially here? So if this was just squamous cell carcinoma in situ, it wouldn't invade cartilage. No benign cell should invade cartilage. So this is a beautiful example of a superficially infiltrating primary squamous cell carcinoma of the lung. Okay, and you know it's probably primary because it seems to be primarily located within the bronchus, not peripherally from somewhere else. So kind of memorize that quickly as well because it's a great slide. And now let's look at the second most common type. In fact, some people even say the adenocarcinomas are more common than the squamous cells. It doesn't matter. The adenos and the squamous cells together are the vast majority of not only non-small cell cancers, but lung cancers in general. Okay. Oh my God. Well, you can see some relatively normal lung here in the northeast. And you see a mass. It's a pretty well-defined mass, but it has jagged edges. Okay, and it looks like this may be a pleural surface. And remember, the adenocarcinomas are more likely to arise peripherally in the lungs rather than centrally. Why? Because there are no big bronchi peripherally in the lungs, so the most common type of cancer to arise in a non-bronchus would be an adenocarcinoma. And look, do you agree that these are probably lymphocytes up here that are perhaps trying to contain the malignancy? And I also know what you're saying. You're saying, well, he's caught this. You're probably saying this joker is probably calling it an adenocarcinoma, but I don't really see glands. Well, that's why we have high power. Look at that little cluster of glands. Look at that little cluster of glands. Look at that little cluster of glands. These are probably 50 little clusters of circular, tubular, glandular things. Now, let's say you looked at these things and you say, well, they don't have terribly big or dark or bizarre nuclei. Well, but they're infiltrating all over the place. So you don't really have to go to the nuclei to diagnose malignancy. Here, I'll zoom in even more. Okay, these are haphazardly infiltrating malignant cells. Let's see if we could move it around a little bit. Here we go. This is, sometimes it takes a couple of seconds between when I see it and you see it, but I know you could all see this little cluster of cells now. These are malignant clusters of glandular cells. Now, could they be mucinous? Yes. Could they form papillae? Yes. Okay, so, but for all practical purposes, an adenocarcinoma is an adenocarcinoma. Oh, and let me show you that cluster of lymphocytes that we saw on low power. I called them lymphocytes, but all you saw were dots. So let's go to an area like here where we saw these bluer areas, like here. And let's blow it up. And yeah, these are lymphocytes. And I know what you're thinking. You're probably thinking, well, why can't this be small cell carcinoma? Well, I've made the mistake myself in real life because both of them are primarily nuclei and small, but these have the classic appearance of lymphocytes, and they don't mold, they're not necrotic, and they are in a reaction to the tumor. So here's my question to you. You could answer it or you could just remember it. Everything else being equal, what kind of cancer do you think will probably be worse? One that has a lot of lymphocytes surrounding it, or one that doesn't have many lymphocytes surrounding it? Well, these are immune cells, These are lymphocytes, there's basically trying to contain the tumor. So everything else being equal, the malignancies which have an immune lymphocytic reaction do better than the ones that don't. Okay, let's go to the next one. Oh, you know what? We're really doing well. Looks like we can. Oh yeah, here's another nice one. Oh, here's something called metadeno. Let's take a look at that. So here's my question. And it's the easiest question in the world. Here's lung again. You could see almost all of the peripheral areas are lung. But then you see a nodule or a density, or tissue that has no air spaces. And if you look closely, you could see that they're basically glandular as well. So I think I could convince you very easily this is also adenocarcinoma. So here's the question. Do you know, just from looking at this slide, whether this is a primary adenocarcinoma or a metastatic adenocarcinoma? Just from the appearance alone, you really can't tell because an adenocarcinoma looks like an adenocarcinoma. However, if I told you that there were 30 or 40 of these things in the lungs all over, you'd probably say it's metastatic, okay? If I told you that it was just one near the pleural surface and some of the lymph nodes nearby were positive, then you might think it's probably a primary. But make no mistake, an adenocarcinoma like this could be either primary or metastatic. But let me ask you another question. Let's say that you did immunoperoxidase or stained for the antigens on these glandular malignant tumor cells. And you discovered that they have the same antigens as some of the cells of the pancreas, let's say, or the prostate, or the breast. Well, then you would know they're probably metastatic, wouldn't you? Okay, that's pretty logical, I hope. Want to move on? Well, we showed you adenocarcinoma, we showed you squamous cell carcinoma. Let's show you something here called large cell carcinoma. This is also non-small cell. It would be obvious that a large cell is not a small cell. So here we go. Well, what do you see? I don't know. Could this be a piece of cartilage? I can't really tell. But let's take a look at the big picture here. We can see connective tissue, and we can see darker tissue in here and darker tissue here. So let's zoom in on it, perhaps like this, and look at these big, dark, ugly cells. Any person in the world, including you, should know instantly that when you see cells where the nuclei are this big, this dark, this bumpy, this irregular, that it has to be a malignant process. And they're not small cells, are they? So if you saw glands within this, you might call this a poorly differentiated adenocarcinoma. If you saw areas of keratinization, you might call it a poorly differentiated squamous cell carcinoma. But in this whole piece, and including all the tissue, there's no differentiation at all, and the cells are large, and they're not small. So you would probably call this a large cell undifferentiated carcinoma. And if you stained the cytoplasm of these large undifferentiated malignant epithelial cells, they'd probably have the same type of antigens that you might see with adenocarcinoma or squamous cell carcinoma. Okay. What about this one here? We talked about all of these non-small cell carcinomas, but here's something called small cell carcinoma. Gee, I wonder why it's called that. Well, they are not generally derived from the same types of cells that the non-small cells are, but you will agree with me that most of these cells are not only small, but they look like they're crushed. They often talk about nuclear molding, which means the nuclei are not round, but they're crushed or molded because of the fast growth. Another thing that you should know about small cell is that it grows faster in general than the non-small cell, and therefore it's more likely to have necrosis. So let me see, can I convince you that maybe this is necrosis, or maybe it isn't? This one doesn't look like it has much necrosis, but let's see. No, this is not necrosis. This looks like it's more like a fibrosis. So this is classical small cell carcinoma. The bad news is it grows faster, it has a higher mortality. The other bad news is that it may result, because it's of neuroendocrine origin, in a paraneoplastic excessive endocrine production syndrome. The good news is it's not nearly as common as the non-small cell carcinomas. Okay, let's go to the next one. Well, let's see. How about... Oh yeah, here we go. Here's an interesting one. Well, I think you could see lung here, right? Some perhaps even over inflated alveoli, but certainly recognizable lung tissue. But what about this stuff down here that doesn't have air spaces? What the hell do you think that is? Well, let's zoom in on it and see. Oh my God, they look like skeletal muscle fibers. In fact, maybe we could even fantasize that there's some striations. Let me see if we could find some striations on here. Okay, folks, maybe we don't have the best... Oh, here we go. Here's beautiful striations. Here's striations. So this is striated muscle. So why would you have lung directly plastered up against striated muscle with only some fibrous tissue in between? And here's the chest wall, skeletal muscle. Here's the lung. And here's a solid core of fibrous tissue. This is an adhesion, okay? Anytime the pleural surface is irritated or inflamed due to pleuritis, not just the visceral pleura, but the parietal pleura, it could result in fibrosis. So in that part of the lung would not have an open airspace, but it would stick. Now, if you have dissected through many bodies in your anatomy class last year, you would find that probably many of the elderly people, especially those who had a history of pneumonia, the lungs might not have come out that easy, but they might have been kind of stuck to the chest wall. These are very, very, very common, and these are fibrous adhesions, because isn't fibrosis one of the sequelae of inflammation? So if this area had been inflamed, it would be stuck, the lung would be stuck to the chest wall. Okay, let's look at some more stuff over here now. We showed you a bunch of pneumonias, acute bacterial, purulent or pyogenic pneumonias in which neutrophils were the main cells. And I think I could convince you that at least down here you can still see some residual air spaces, or even over here. But what about this cluster of cells here in which you don't really see any normal lung framework at all? In fact, all you see here are neutrophils. And maybe there's some residual of alveoli here, but look at this is 100% pure polys or neutrophils. This is a lung abscess, and it's one of the common features of any acute pneumonia that has been not under control or progressed, okay? This is a lung abscess. If it was, for example, an abscess due to aspiration, you might even see food particles. Now, I see a little necrotic debris over here. I don't know if that was food or not, or whether that's just necrotic debris. So that's a lung abscess. And I think there's something I was very eager to show you, but what is it? Oh, what I wanted to show you was this. Do you remember we said that the bacterial pneumonias or bacterial infections in general are characterized by neutrophils? And in the case of bacterial pneumonias, you see the neutrophils inside of the alveolar spaces. Well, in this type of pneumonia, you can still see air spaces, but you don't see neutrophils. And the primary part of the lung that is inflamed are not the alveolar spaces, but it's a thickened septae or walls between the alveoli. This is the interstitium. So this is an interstitial pneumonia rather than the usual type of bacterial pneumonia. Interstitial pneumonias can result in fibrosis. Interstitial pneumonias are more likely to be viral rather than bacterial. And it could very well be that this was a COVID patient. This could very well be what I had last year, okay? And could this result in fibrosis perhaps occurring for a long time? Yes. Could interstitial pneumonias be secondary to irritants or nosocomial infections, exposure to radiations, dust, cold? Yeah, this is a non-bacterial, possibly viral type or nosocomial type of pneumonia. Okay, that's interstitial pneumonia. Why? Because it's the interstitium that has the inflammatory cells. Probably mostly lymphocytes, not neutrophils, but the alveoli themselves are pretty clean. Here, let me blow it up a little bit more. Here we go. Yeah, look at the inflammatory cells are in the interstitium and the alveoli are pretty clean, and the inflammatory cells are mostly lymphocytes rather than neutrophils. Interstitial pneumonia. Okay, how about if we go into something like this? This one might even fool you. I was debating whether I should really show you this one or not. But in this lung, I think you'll agree that is not quite as spongy as it should be. But you do see the inflammatory cells occurring in little balls, little clusters, like here, and here, and here, and here, and here. It's not like a diffuse sort of a thing. So let's blow up one of these little balls. Like maybe over here, there's a couple of them. Guess what? Do you see giant cells? Do you see macrophages? These are granulomas, okay? And these are granulomas which do not look like they are necrotic on the inside. So you might call these non-necrotic or non-caseating granulomas. And this is the classical appearance of a disease called sarcoidosis, which we said was basically an autoimmune disease because it's a granulomatous disease and it's not caused by any specific known pathogenic organism. Here's another lung. And can I also convince you that these are even bigger clusters of cells? And can I convince you perhaps that these may be granulomas also? Okay, well if not, let's blow it up. And look, these are little granulomatous balls. How do you like that? And furthermore, let's see if I could really show you something cool here. Or maybe we might have to move to another field. Oh my God, look at that. That has like a little ring around it. And so does that. And so does that. And so does that. And so does that. So let me ask you, are those cells or are those spherules? Actually, this is blastomycosis granulomas. Blastomycosis is a chronic granulomatous disease. But when you see these little walls around the center portion, that's probably not a cell. That's probably what they call a spherule, okay? So this is another type of granulomatous chronic pneumonia, like sarcoid, only this one has a specific cause. It's an organism, a fungal organism. What else do we want to show you? We're almost near the end. Let's say we do one more and we'll call it a day. How about if we do something like, how about something, or did we show everything already? Actually, we did. Folks, we're done for the day. And I can't believe we actually showed all these slides in an hour. I hope I didn't go too quick. So how about if we close it down and we play our final song. And you know what we're going to say at the end.
Good loving, I got a trouble on it. And when you get it,
Well, you know I'm going to say rock on buzzards. I've been doing that for the last 10 years, 12 years. But we're also going to show you the buzzards on rock. And the other last two things I wanted to say, other than rock on buzzards, was that I'm really proud of these webinars because I don't think there's any other online course that gives the students free coffee. But I also wanted to warn you that the next webinar, which will be in 46 hours, will be starting the genitourinary system, and there's a whole bunch of those. There's probably about 10 of them. So it might take us about a month before we're done with it, but I'll try to make it as entertaining as possible, at least for myself anyway. So what are we going to say? Well, let's pull down our little closing thing here. That will say exit webinar. And let's turn off our little movie maker, which is going to be right here. And we're going to say, rock on buzzards.